Pathophysiology of rectal prolapse. Rectal prolapse is the protrusion of the rectum through the anus, which can occur in partial or complete forms. Its pathophysiology is complex and involves several contributing factors. 1. Pelvic floor weakness. The primary underlying issue in rectal prolapse is a weakened pelvic floor. This weakness leads to the inability of supporting structures to maintain the rectum in its normal position. 2. Anal sphincter dysfunction. Weakness of the anal sphincter muscles exacerbates the problem, allowing the rectum to prolapse through the anus. This contributes to fecal incontinence. 3. Loss of rectal fixation. Normally, the rectum is anchored in place by the sacral fascia, ligaments, e.g. the uterosacral ligament in women, and the mesorectum. Loss or loosening of these attachments predisposes the rectum to prolapse. 4. Increased intra-abdominal pressure. Chronic straining due to constipation, chronic cough, or other causes can increase intra-abdominal pressure, forcing the rectum outwards. 5. Neurological factors. Damage to the nerves supplying the pelvic floor muscles and anal sphincter, such as from spinal cord injury or childbirth, can also contribute. 6. Anatomical variations. A deep pouch of Douglas, cul-de-sac, or redundant sigmoid colon may predispose individuals to rectal prolapse. 7. Age-related changes. Age-related weakening of connective tissues and muscles is a significant risk factor, making rectal prolapse more common in elderly individuals. 8. Other factors. Chronic diarrhea, rectal intussusception, prior anorectal surgeries, or connective tissue disorders like Ehlers-Danlos syndrome can also increase risk. Clinical features. A visible protrusion of the rectum through the anus, mucus discharge, bleeding, or ulceration of the prolapsed tissue. Fecal incontinence or constipation, sensation of incomplete evacuation, pain or discomfort, especially during defecation. In severe cases, strangulation and ischemia of the prolapsed tissue. Treatment of rectal prolapse. Treatment depends on the severity of the prolapse, patient comorbidities, and preferences. It can be categorized into conservative management and surgical intervention. 1. Conservative management. Dietary changes, high-fiber diet, and adequate hydration to manage constipation and reduce straining. Pelvic floor rehabilitation. Pelvic floor exercises, e.g. Kegels, and biofeedback therapy can strengthen the supporting muscles. Laxatives, to prevent constipation and reduce straining during defecation. Avoiding triggers. Minimize activities that increase intra-abdominal pressure, like heavy lifting or excessive coughing. Surgical management. Surgery is the definitive treatment for rectal prolapse and is typically required in complete prolapse cases or when conservative management fails. A. Abdominal approaches, preferred in younger or healthier patients. Rectopexy. Fixation of the rectum to the sacrum using sutures or mesh. Types. Open rectopexy, involves an open abdominal incision. Laparoscopic rectopexy, minimally invasive, shorter recovery time. Resection rectopexy, combines rectopexy with resection of a redundant sigmoid colon to address constipation. B. Perineal approaches, used in older or high-risk patients. Delorme's procedure involves excision of the mucosa and plication of the muscular layer of the prolapsed rectum. Altemeyer's procedure, perineal rectosigmoidectomy, excision of the prolapsed rectum through the perineum, often combined with reinforcement of the pelvic floor. C. Combined or tailored approaches. In complex cases, surgeons may combine techniques or tailor the approach based on patient factors. Postoperative care and complications. Postoperative care. Pain management, bowel regimen to avoid constipation, and gradual return to activity. Complications. Recurrence, infection, constipation, incontinence, and mesh-related complications in cases of mesh rectopexy. Prognosis. With surgical treatment, most patients experience significant improvement in symptoms and quality of life. Recurrence rates depend on the surgical technique and patient compliance with postoperative care.